Thank you very much for this wonderful invitation. And arriving in Philadelphia from Baton Rouge, Louisiana, it's warmer here on Sunday when I arrived than it was at home. And so thank you for the very, very warm welcome. I'm going to bring our conversation to a very local level in Baton Rouge, Louisiana. Many of you know Louisiana as a very poor state. But I bring great news that there are individuals who are working to transform lives and transform care in the state of Louisiana, and we would not be able to do that certainly without the assistance of government funding. I chose to use slides because I wanted to be able to make the work that we're doing in this case study very relevant. And so I'll start with a few comments about who we are as a health system. The Franciscan Missionaries of Our Lady is a primarily Louisiana-based health system. We now have one hospital that we recently partnered with in Mississippi that provides care in Jackson, the largest metropolitan area of Mississippi. We have 6 hospitals in our health system. The sisters who sponsor our ministry have been caring for the poor for more than 100 years. We provide millions of dollars of unreimbursed care as well as services to underprivileged individuals. The health system takes care of almost 50% of the citizens in Louisiana. We also are an active participant in the CMS Next Generation ACO. We have several risk-based products in commercial, and what we've done is to make sure that all of our risk-based products operate under the same system. So if you're getting care in the safety net system, if you're getting care in our commercial system, we have put together a system and structure for that to be the same. I hail from Our Lady of the Lake, which is the flagship organization in Baton Rouge. We are the largest hospital in the state on a single campus with more than 800 beds. We are the second largest provider of care to children in the state of Louisiana, and we also operate health centers and schools and school-based clinics within that area. We have a rural hospital that's a part of our network, as well as the Franciscan Missionaries of Our Lady University, where we educate baccalaureate-prepared nurses, CRNAs, and nurse practitioners. Louisiana has a long and storied history of providing care to the poor, which started when Charity Hospital in New Orleans opened in 1736. We went on in Louisiana to build a safety net indigent network of hospitals across the state of Louisiana. However, in 2013, the decision was made to establish a public-private partnership and to put the care in those regions in the hands of the individual organizations. We, Our Lady of the Lake, stepped in the shoes of the state in Baton Rouge. We also had a community needs assessment done at the time. We were recognized by the American Hospital Association for being the only community where the healthcare providers came together and not only did a community needs assessment, we put together a community implementation plan to address the priorities that you see before you. As a part of this partnership, we thought about, as we began to step in the shoes of the state, how might we do this? And as the chief operating officer at the time, I thought back to the legacy of Charity, and I thought back to the work that we had done. I was sitting in the command center at Our Lady of the Lake during Hurricane Katrina. And our command center actually became more than an internal command center. It became a resource for people to call and ask questions. But I received a call from a gentleman who was from New Orleans. He had brought his wife to Baton Rouge for care with the family. He wanted to know, where can I bring my wife for cancer care? I told him, sir, bundle her up and bring her to Our Lady of the Lake. We will take care of her. We're Catholic, we're not-for-profit, we're mission-driven. And he said to me, but you don't understand, I don't have any money. In his mind, Charity Hospital was his place of care. It was the place he trusted. And so as we began to put together our safety net system to replace Earl K. Long, which was a legacy hospital in our city, we thought, how would we put together a center of care, a place where people trust it? And that's the work that we have done. Today, that network consists of primary care clinics, 2 urgent care centers, one that is connected to a freestanding emergency room. It has a retail pharmacy and also specialists across the region. We wanted to make sure that individuals were getting care in the proper setting. Well, today, our results speak for themselves. We have been able to decrease cost by 58%. The baseline year of care was more than $4,000 per day. In year 3, we're at $1,750. How have we been able to achieve these results? We eliminated the primary care waiting list by putting together a nurse practitioner physician hub and spoke model. A physician is put in the center, but we decreased the number of patients in that primary care physician's panel. And then we put the 4 nurse practitioners around the physician and fully populated their panels. So what happens in that clinic in the daytime is that the nurse practitioner is seeing patients that are appropriate. And then with the physician, if there is a patient who is complex or there is need for the primary care physician, that physician has the flexibility to then step in and to manage that care and to help with those patients. The primary care physician has also partnered with subspecialists, with gastroenterologists, hepatologists to address hepatitis, and orthopedics to develop primary care protocols for those specialists. And so they're making sure that they are caring for the appropriate patient in primary care, reducing referrals, and also reducing the waiting list for specialists because of this model. Our ER urgent care model is also an exemplar. We have an emergency room that is connected to an urgent care center. We teach patients about care when they show up for their care. So when a patient checks in to the emergency department on this campus, and the patient is determined not to have an emergency medical condition, that patient is escorted just a few steps away to the urgent care center and usually cared for by a nurse practitioner. Also, if the patient checks in to the urgent care center and it's determined that the patient has an emergency medical condition, the patient can be wheeled right next door to get emergency care. How has that worked for us? On average, 20 patients per day are directed from the ER to urgent care, while on average, only 5 patients per day are transferred from that freestanding emergency room to our tertiary care campus. We've also improved access to medication by simply putting in place a retail pharmacy with state-of-the-art retail equipment. When we began to operate that retail pharmacy, patients were waiting upwards of 2 weeks for their medication. Today, patients wait 6 to 8 minutes. That funding is a part also of funding from our 340B program. We expanded mental health population management as well. We have now put psychotherapy so that depression and anxiety can be treated in the primary care model. Lastly, in that model, we've linked the ambulatory setting to hospital-to-home programs. Meds to beds. We make sure when a patient leaves the hospital, the discharging nurse sends the medication order to the pharmacy, and medications are brought to the patient so that the patient has their discharge meds prior to leaving our campus. A care coordinator then calls the patient and assures that the patient is seen for their follow-up appointment and also to make sure that they don't have any disparities. You've heard lots of people talk today about what are the models for value-based care. Value-based care today is really sold on changing the role of the provider and centered on the provider. But we believe that if we're going to address the social determinants of health, that we have to look beneath the surface. The Academy of Oncology Nurse and Patient Navigators have a model that I think is a promising practice. They have linked primary drivers to secondary drivers, which also includes paying. So how do we codify to make sure that when Massachusetts is taking the big step, when New Jersey is taking the big step to pay for navigation, how do we make sure we define navigation in the realm of the social determinants of health? Navigation has its beginning in Harlem to address the social determinants of health and developing a data system so that we can make sure that navigation is accounted for and paid for, where our nurse care coordinators are really making a difference. We know that in our health system that nurses are working to the top of their license and they're working to make a difference. Registered nurses in our ambulatory setting are coaching and counseling. We have demonstrated $9 million in the Medicare Shared Savings Plan. We've seen improvements in the management of diabetes, improvement in hypertension. Our nurse navigators take care of what we call familiar faces. They're patients who've been to our emergency room more than 5 times in 6 months. Those patients are then connected with a care coordinator. A care team is put together with the patient to talk about how can we help you to get care at the right time, at the right place, in the right setting. Our care coordinators also make sure that they enroll patients in food assistance programs to address food insecurity, to make sure that our patients are taken very good care of. We believe that all nurses, whether they're UR nurses, nurses who are navigating, the bedside nurse working with meds to beds, or the ambulatory nurse, that all of our nurses are key in addressing health disparities. So as we've talked about today, what is our next thing to do? We believe that the drivers of change in value are grounded in access, team-based care, metrics and incentives, and partnerships. Yes, access. If we had not expanded Medicaid, if we had not participated in Medicaid expansion in Louisiana, we would not be having the outcomes that we have today. Access to care is important. Access to primary care, which we've heard talked about, is important. And our nurse practitioners and the work they're doing is God's work. Access to medication. We know that there are studies recently that talk about the health disparities and the racial discrimination in how medications are prescribed in our country. Access to medication matters. Healthcare is a team sport. All of our clinicians have to come together and work to make a difference. However, how nurse navigation and care coordination is funded in team-based care has to be explored. Every nurse in every setting, every day, is delivering value and making a difference. But we won't know that difference without metrics and incentives. How do we make sure that our data systems, as we discussed, are linking the positive impact? Great work around flexibility to pay for transportation by CMS, by telehealth. All of those things are promising. However, we have to expand our metrics to include that the care that is delivered, that intervention was delivered by a nurse. Additionally, our financial incentives in these risk arrangements should go beyond the provider. Many of our incentives are stopping at the provider level, and the caregivers who are making a difference in moving the needle are not participating in those incentives. And lastly, partnerships. Partnerships make a difference. Innovation cannot happen without a public-private partnership. We know that the not-for-profit philanthropic community deserves credit for much of the funding of nurse navigation and care coordination. So from wellness to prevention and advocacy to outreach, nurses in our health system and nurses around the country are doing God's work on behalf of the human condition. As Florence Nightingale spoke about the art of nursing in caring for the temple of God's Spirit, our people who we care for need nurses, the superheroes, to change and address the social determinants of care that are barriers to care that complicate the outcomes that we achieve in this country. Thank you.